Good afternoon. We are here for the 2 o'clock session of medications and remission. We are going to have Dr. Syed do a presentation. She is an adult and pediatric rheumatologist who trained in St. Louis University in 2019. After 12 years of serving at St. Louis University, she joined Washington University School of Medicine and takes care of adult, peds patients requiring rheumatology care. She is the director of a transition clinic which helps young adults transition smoothly from pediatric care to adult healthcare system. She also is the director of a lupus clinical trial and has 3 active studies. She is passionate about providing the holistic care and her patients and her families. She's going to be presenting for about 50 minutes. After that, she will have a question and answer time, and we'll pass the mic around that she'll be able to help answer some questions. Please give a warm welcome to Dr. Syed.
Hello, everyone. Can you hear me? Okay, perfect. Hi. So I wanted to thank actually the organizers for inviting me to speak because I'm so passionate about children with any rheumatologic disorder, especially juvenile arthritis. So thank you so much to the organizers. And as Jim said, I am an adult and pediatric rheumatologist, so I see a lot of children transition to the adult side, and those kids who've done well on the pediatric side do great as adults. And so, this is a very important topic that I'm very passionate about. So we'll get started. He introduced me. So I'm an adult pediatric, Michigan State, moved on to St. Louis U. I've been practicing since 2007. I was at St. Louis University and then came over to WashU just to get something new. And I'm enjoying myself, and I really do help transition the kids, and I do some lupus studies, which is really my passion. Juvenile arthritis, really there is no cure for juvenile arthritis. It's an autoimmune disease. But what we're happy about and excited about is that we can put it in remission. I'm not going to talk about CAR T therapies, but that is kind of like the new frontier, and that is helping put other diseases in remission. And maybe there'll be something like that for GIA in the future. But right now we're going to not include any of that. Your child can live a fully healthy quality of life and do everything that they want to do. And really that is the goal for the physicians along with the family. Okay, so I think you guys probably got an overview of what JIA is, but I just want to briefly touch base because the form of arthritis the child gets makes a difference on their future outcomes and prognosis. There's oligoarthritis where there's 5 or less joints, and then there is polyarticular where there's multiple joints involved, and there's systemic when there's fevers and rashes along with the joints. Oligoarticular arthritis is the most common form of arthritis that we see, and it's the form that actually a lot of kids will go into remission, and a lot of them can come off medications. The other forms can go into remission and stay in remission, but a majority of those patients tend to require medications to stay in remission. So defining remission, really what we're talking about is a disease that's without activity, and we use many different kind of scales for that. So we'll ask in clinic about any swelling in the joints, stiffness in the joints, pain in the joints when they're using or doing their sports. All those 3 components are very important. For the systemic patients, we'll ask the systemic symptoms, fevers, rashes, fatigue, malaise, all those things. We'll talk to the eye doctor, find out about any eye symptoms that they may be having. And we'll review the labs, but you guys are parents of GIA children, and you guys know that labs can be completely normal and that there could be still disease activity. So it really is a very 360-degree approach to figuring out if your child is in remission. And then there's the physical global assessment and other assessments that we use, like JDAS and such, that to assess if there's any activity going on. Stiffness, less than 15 minutes is okay, but it's really, when it's more than 15 minutes, especially first thing in the morning, that's when there may be disease activity going on. And each child's disease is different, and each child's remission is different. And so what is the goal? So we really sit down and talk. So we have athletes coming in, we have kids who are not athletes, but, they have other goals and ambitions. And so we really need to kind of assess, like, okay, what were you doing before this happened? And where do you want to be, once the medications are working and you're in remission? So I have soccer players and, swimmers and basketball players, and some of them just want to get back to their sports. And then there's other kids who just want to graduate from high school and go on to college, and they want to be on their own and not be bound to, having to be close to us because their disease is active. So all of those components are very important to us. I just briefly touched on this, that labs can be very clean, meaning the ESR is in the normal zone, the CRP is also normal, there's no anemia, the white cell counts, the platelet counts are good, there's nothing there on the labs, but the child still could have pain or swelling or limping, not able to move the joint as well because it hurts to move the joint. So we pay attention to all of that, and that's why it's important to be coming to the clinic visits, So during COVID times, it was hard for us physicians to tweak the system and do virtual visits, and, I had kids standing on chairs and trying to do all their maneuvers, but I was still thinking in the back of my mind, like, oh my gosh, am I missing something because I'm not able to touch those joints? And so from that, what I learned is, having the kids come in and examine them there's nothing compared to that. So very important, but virtual visits have really helped us outreach, the rural areas and kids who can't come all the time. So that has been actually a good addition. So I talked about this. So the holistic 360 approach is really what we want to do, right? We really want to address everything, and there's going to be a lot of talks on this, the various topics during this whole summit, so don't miss those sessions. But I really focus on exercise because exercise builds joint health. We talk about diet. There's lots of studies happening in many autoimmune diseases and rheumatologic diseases especially that suggests that what we eat makes a difference on the inflammation that the children and kids and adults with arthritis have. So the diet definitely makes a difference. Sleep. Sleep helps build the immune system, so that's really important. We address that. Shoes, a lot of times really good arch support such actually helps the joints feel better sooner. And then kids can have, in addition to their arthritis, they can have amplified pain syndrome, and that really does need to be addressed. And it could be with the help of pain management and psychologists or counselors, that we do this holistic 360-degree approach. So the medications, before we talk about medications that we need, so before, and I am old enough, so I started my rheumatology fellowship in 2004, and at that point, when I was joining, people were telling me, why are you going into rheumatology? The only thing we have is prednisone, and all these people are on prednisone all the time. And really, in 1999 is when all the biologics were coming to market. So 2004 was really kind of new. And I actually joined because the paper got published on etanercept. And Dr. Terry Moore, who's the head of St. Louis U Rheumatology, he had come and given his presentation at our facility in Michigan State. And I said, this is what I want to do. I'm really passionate. This is what I want to do. And so, but I saw kids with the pictures that you're just seeing right now, kids with small jaw, mandibles because it just didn't grow. The TMJ arthritis caused this kind of micrognathia. The contractures in the joints that you guys are seeing in the bottom picture on your right. The leg length discrepancy with limping and then hip problems and back problems. We used to see this in clinic. And now we should not see this. If this happens under our watch, we're not doing a good job controlling the disease. So we really need to be aggressive because we do not want any growth problems. We do not want any joint contractures, and we don't want to be engaging orthopedists for any joint replacement because we really do have fantastic medications. So there's various types of medications. You guys are probably aware in oligo-GIA with 4 or less joints, we can start with non-steroidal anti-inflammatory or steroid injections, but often we need to move over to conventional disease-modifying agents. So DMARDs as disease-modifying agents in rheumatic diseases. So there are methotrexate is kind of the gold standard. Every medicine that comes on the market has to be at least good as methotrexate to be considered for FDA approval. So it's a really fantastic drug, but not every child can tolerate that. So there's leflunomide, there's sulfasalazine, there's hydroxychloroquine, and some kids require a combination of these medicines. This is not, steroidal based, so it doesn't have the same side effects as prednisone and other steroids. But it does require more long-term monitoring of the white cells and your liver function and the kidney function. But kids do really well. They have really healthy, organ systems. They don't have many disorders, and so they really tolerate these medications well. But, some kids then don't go into remission. They're still having pain, swelling, or stiffness, so we have to move on to biologics. And there's studies done that, being aggressive and moving on to biologics sooner is better for joint health. And you may have heard of etanercept, adalimumab, infliximab. Those are the ones that got approved in 1998. But since then, we have many biologics for juvenile arthritis, including tofacitinib and tocilizumab and Rinvoq, which is Upata. That's come on the market, and then there's also Simponi, which is a humanized infliximab molecules that's being used in pediatric patients. So there's many medications, and there's abatacept as well. So we have many choices for biologics. Some are injectables, some are infusion, but it just depends on what exactly your child needs and what the insurance will approve that we will go with that. And there's more on the pipeline, and right now we don't do combination biologics, but there's some thoughts about the JAK inhibitors, which is the tofacitinib and Upata. Those medications are, if they're safer, could we potentially combine it with some of the other biologics, because some kids may have Crohn's disease and arthritis in their joints, and they may require that inflammation control in the GI tract plus the joints, and so we're talking to the GI team, and we do have some patients off-label with that combination. So maybe that in the future we'll have that as well. So we don't talk about narcotics, but some patients may require that periodically. But there are lots of studies talking about chronic pain, not really reaching out for narcotics for chronic pain because of the epidemic that now we are dealing with right now. So really we need to be aggressive with our conventional and biologic disease-modifying agents so the kids truly go into remission and we're not just treating pain with a Band-Aid, which narcotic medications could be. So there is no one pathway. Which medicine is best for your child really has to be individualized. It really has to be, what other medical problems do they have? Do they have a sensitive GI tract? Do they have other potential, illnesses that would hinder them taking something by mouth versus something that's injectable? So we really tailor it to the child. But methotrexate really is kind of the go-to medication. We try to talk about it with every family member and the child, and figure out if that would be a good choice for the child. It's available as sub-Q injections. It's available as oral. And the availability when you inject it is better. So for some kids, we may actually offer it, who are older or heavier, we may offer injectable because you end up getting more absorption of that medication versus the oral, because after 15 milligrams, there are studies that it may not absorb as well in the bigger kids. So that's something to consider. But really, at 3-month mark, your doctor will call you back because if in 3 months the child is not completely pain-free, swelling-free, stiffness-free, we need to think of the next medication. And it's kind of an add-on process. We don't take the conventional DMARD off. We add a biologic to that. And so 3 months really is it. So if in 3 months they're 50% better, but they're not 100% better, we're going to continue, another medication. We're going to add another medication, and then see them again in 3 months and see how they're doing. If in that 6-month mark, which is 3 months with a new biologic medication, if they're not better, then we may switch the biologic out. So really that is the goal, every 3 months, because it takes 3 months for our medications to work. There are studies, especially in polyarticular GIA, which have shown, this study was done with CARA, CARA's registry, and it's shown that if you don't treat polyarticular GIA aggressively, then you can end up with kind of this chronic smoldering disease and joint damage. So for polyarticular GIA, we definitely try to be very aggressive, and some patients may actually start biologic medications in the very beginning, along with a conventional disease-modifying agent like methotrexate. So it could be your child's rheumatologist talks about 2 medications at the same time because they have more aggressive disease. So again, we want to be aggressive. Patients with oligo-GIA have, especially with a positive ANA, have a very high chance of getting involvement of the eye, which is uveitis, inflammation of the eye tissue. In some studies, it was up to 70% with the positive ANA. So again, we're really closely working with the ophthalmologist, because it doesn't show, the child won't say my eye hurts. It's what we call silent uveitis, meaning there's no redness in the eye, there's no tearing, the child's not rubbing their eye saying, it hurts, but there's this smoldering inflammation going on. And so we definitely need an ophthalmologist to be paying attention. If the ANA is positive, they should be going there every 3 months. If the ANA is negative, they can kind of space out the visits a little bit more, but the chance of uveitis is higher in the oligo-GIA patients. And so sometimes we'll be using a biologic disease-modifying agent like adalimumab, which is Humira, to help control the eye disease. And the joint disease is already in remission, but we're really trying to be aggressive about controlling the eye disease to prevent chronic damage to that tissue. And systemic GIA, so systemic GIA, because it involves more tissues, so for instance, the tissue around the heart, the tissue around the lung, and it can involve the bone marrow as well, and lead to an inflammation called macrophage activation syndrome, which is the immune system kind of going really haywire and causing the white cells to kind of gobble up the red blood cells and platelets. And so the kids are spiking fevers, and they are just feeling really sick, and their blood work looks, really bad, like low white cells, low platelets, low hemoglobin, and there is an inflammation number called the sedimentation rate, which will be actually low. It won't be high, even though they're very sick. So that's how we identify this complication of systemic GIA, because systemic GIA can also cause fevers and malaise and just feeling sick. So how do we tell the difference? Like, is this the actual disease, or this is a complication of the disease? We really look at the labs, and if that's seen, we need to be aggressive with treating the juvenile arthritis, but we also need to add other medicines to treat macrophage activation syndrome, and we have a lot of biologics to help control that. But the underlying disease definitely needs to be in control, because the chance of getting macrophage activation syndrome is less if the systemic GIA is under control. One of the things I tell the parents is that you are your child's advocate. This is a teamwork. This is long-term relationship. You are your kid. Maybe 2 years old, 5 years old, and so they can't speak up, but you are their advocate. So if something's not working, it's good to have that conversation with your rheumatologist, because they may not know that, hey, the child, the day that they're supposed to take methotrexate, is crying all day or running around not wanting to take their medications. You want to have that conversation with the rheumatologist, because we have other options. We can work. Of course, we want the best medicines, but if it's just not working for you, for the child, we definitely want to know about that. Also, we really want to know if the child is not participating in sports and they used to be an athlete. We want to know, and we want you to let us know, like, hey, I don't think we're being aggressive enough, because my child is still not pain-free, or they're still not, stiffness-free in the morning, they're still limping. We want to hear about that. So really be your child's advocate. And remember the 3-month mark. So if your child gets diagnosed today and they start treatment today, then 3 months is really when, you should see, results. So in 3 months, if they're not adequately controlled, we need to move on, and we need to know if your child's not doing well. So keep that appointment, talk about the visit, like how they've been doing the last 3 months so that a good decision can be made for your child. Okay, and then of course insurance companies. So we may have amazing, ideas about how to treat, but sometimes the choice of biologics really ends up being on what the insurance has decided they will contract with. But the good news is we have a lot of choices. Okay, so we can, and then we really do the prior authorization process, but we do appeals. If we as physicians and parents feel like, hey, you know what, they've already failed this, or this medicine caused side effect, then we write letters. It's called letter of medical necessity. We do that. And so your physician will help you get that to the insurance company to justify why we're going down the path we are. So again, have that conversation with the rheumatologist, and if all the parties feel like, hey, this is the only medication, we can get around that with letter of medical necessity, appeals process, peer-to-peers, and really trying to get the medicine approved. And of course, still, sometimes the insurance gets back, like, no, you need to try this medicine for 3 months, and then we just have to do that for 3 months. So there are medication side effects, of course. The way I think about it is anything that can have a reaction can have a good reaction or a bad reaction, right? So I give this example to the kids that walk in my clinic, like, hey, strawberries are really good for you. But if you're allergic to strawberries, you could have swelling of your tongue and difficulty breathing and a rash. The sun is really good for you, but if you're out there too much, you can get a sunburn. So anything can have a good reaction, can also have a bad reaction, and medications are the same way. What we have learned over the years, though, is that, again, being aggressive with treatment has better outcomes for the patient. The leading cause of disability in the United States is arthritis, and so we really want to be aggressive in the beginning, and we want these kids to live a full, very happy quality of life, which means, if they want to go to college, they should go to college. If they want to be athletes, they should be athletes. They should not have this as a limitation. There should not be a limiting factor in their life. So we really want to be talking about medications. So I myself believe that the pros outweigh the cons, but I do have families that they talk about, hey, I want to be on more natural medications, and so we have that conversation, and that we really have an open dialogue, and I think that's a very important point. Like, I have patients saying, hey, we went to the naturopath, and we are giving extra turmeric, and we're doing this. Again, anything that can have a good reaction can have a bad reaction. I've had adult patients who were taking too much turmeric end up in the hospital with liver issues. So it's a natural thing. So just everything in moderation. Have the conversation. My own son last year, he's 19 now, but last year he got diagnosed with ankylosing spondylitis. So I am in your shoes, and it's ironic. So when your child has those symptoms, you're in denial because you've been seeing it for 15 years. And you're like, oh my gosh, this can't be, But I was lucky enough that my partners are all rheumatologists, and so I could get him in soon. I could get the MRI done soon. I could get him on biologics. The first one didn't work. He developed antibodies. Then we moved on. So I can say I can feel as parents what you guys feel, like, hey, what about 10 years from now, 20 years from now, when they want to have kids, but it's a better quality of life when they don't have chronic damage, for sure. And so I am a very firm advocate for the medicines that are right now on the market. Okay. So some of the side effects that you want to talk to your doctor about. So non-steroidal anti-inflammatory can cause a lot of GI issues. And rarely in kids it can cause kidney issues. Liver issues is really, really rare. But GI issue is the most common problem. And so some kids they wake up in the morning and they're running for school and they won't have breakfast, but then they'll take their naproxen or meloxicam, and that's the biggest problem. You can't take this without food. So even a little piece of toast, a glass of milk, just to protect the stomach is just really, really important. Corticosteroids is my best friend and my worst enemy. So it really helps with bridging to get to the next medications because the medicines take 3 months to work. But long-term corticosteroids is not the way we want to really proceed with treatment. I've seen osteoporosis, I've seen avascular necrosis, I've seen growth, stunting, diabetes, high blood pressure, and for kids, the weight gain and the stretch marks. It's not a long-term solution, but for short-term, it's called bridging therapy. For short-term, it's very important to use it as intra-articular injections for some kids, especially oligo, when they only have one knee. It's brilliant. You can give it and they can go into remission and not need any medicine for 6 months or maybe a year or maybe even longer. So we definitely use intra-articular if there's one or less, or two or less joints. We try to do that. The methotrexate. Methotrexate, what it does is actually blocks the way folic acid works in our body, and so we can get folate deficiency, which is a form of anemia, and so. That's why your doctor will say, hey, when we're starting methotrexate, we're going to give you folic acid as well. Folic acid's great for the hair, but it really protects the mouth from getting ulcers from methotrexate. It's called stomatitis or oral ulcers. It protects from that, and it protects the GI tract as well. But if your child is getting nausea and oral ulcers despite being on folic acid, definitely talk to your rheumatologist. Methotrexate can also cause liver enzyme elevation, but it's rarer in kids. Again, their liver is very healthy, and they're not drinking alcohol, and they exercise, so their liver is much healthier than grown-up liver. But that monitoring blood work is very important. And then biologics. So biologics, when you read about biologics, and there's a black box warning, especially what I would say, is like cancer. So the anti-TNF agents have cancer. When we did our study, especially with CARA, the CARA, so we have 10,000 kids in the CARA registry, and they were able to look back at the data. The jury's out, meaning that aggressive inflammation in the joints can itself lead to cancer too. So we have data in rheumatoid arthritis, in lupus, in GIA. So aggressive disease is also the group of patients that require biologics, right? And so we still believe that treating the disease will, and putting the patients in remission is actually going to decrease hopefully the rate of cancers. But if there's a strong family history of cancers, it's because sometimes it's a genetic mutation, and if there's a strong family history, that discussion needs to be had, and then a biologic that has less risk of malignancy needs to be decided. But at this point in time, the evidence is lacking from that front. The JAK inhibitors, more for the adult population, can increase the risk of blood clots or heart attacks, and I really talk to that about that with my adult patients. But there could be a child who has a very strong family history, and that conversation can be had. But really, that's not a contraindication for that child to get JAK inhibitor like tofacitinib or Upata if that's what they need. So this slide is just really about how do you go about this? Just really having that conversation again, having a safe spot where you know that it's okay that you and your child are scared. Have that conversation with your primary care physician who may know your child longer. Have it with your the rheumatologist. Get a second opinion if you need to. It's all okay. And then, if your child doesn't have really aggressive disease and you want to be less aggressive with treatment, that's okay. But it's not okay for the life of the child's disease course. It's okay for 3 months, but if they're not doing well, we really need to have that conversation again. Conversation about injections versus oral versus, monthly, weekly, all that conversation needs to be had. And then, like mental health. So mental health is just really, really important. Kids who have chronic disease can have a lot of mental health issues, and the families can have, anxiety and such. And so it's very important, and I talk about that a lot with my kids. Like, maybe we need the school counselor involved. Maybe we need to have you, find your best friend, go out and, have a conversation with them, or maybe a psychologist or a psychiatrist, so we have that conversation as well. Again, outcomes have improved significantly. If your child comes in without any joint deformity, it should not occur under our watch now because we have such amazing therapies. We really can do a fantastic job getting kids, in remission or as close to remission as possible. There are many choices that work very differently. There's injectables, there's the orals, oral biologics that are called small molecule. The names are here, Xeljanz and Rinvoq. That's the brand name. Xeljanz is tofacitinib, Rinvoq is upadacitinib. So those are available to kids as well. And then disease assessment tools. So, we use a lot of exams and joint counts and, how many swollen joints, how many tender joints, if there's stiffness, what's the ESR, what's the CRP, to put together an objective number for the kids and to figure out if they're in remission or not. But those tools are also improving. So medication versus non-medication, what do we do? And really, again, that's a dialogue to have with your rheumatologist, because this is really individualized. Some kids, you have that dialogue, and the rheumatologist says, hey, not right now. Your child has 4 swollen joints. I really don't think we should be not giving them medication. But, if the child had 1 joint and it's in, there's no swelling, stiffness, and they're in sports again, having that conversation like, hey, can we come off the medication is very, very appropriate. So as far as coming off the medication, what do the studies show? The studies show that oligo-GIA kids, 30% will go into remission and stay in remission and can come off the medication and do great. 30% will go into remission on medication, and then we try to take it off. They may have a relapse. And 30% of patients will need escalation of therapy because their disease may become extended, meaning they may have had 4 joints, now they have 5 or 6 joints, and they may require more medication. So, but we know that oligo is the best group to go into remission. That doesn't mean polyarticular GIA patients don't go into remission or systemic onset GIA, but those are more aggressive diseases because there's more involvement of joint tissue and then in systemic other tissues as well. So we really are very careful about watching. Because I do the transition clinic, I do have kids who are now adults. They come in and they have history of systemic GIA or poly GIA, and they're doing really well. And they just come in every 6 months, and they're barely on any medication, or some of them are not on medicine, but I'm too protective to let them not come, so I still make them come to clinic because if they flare, then they're under my watch and I can give them some treatment. Okay. So this is just the data about clinically inactive disease. That's CID, clinically inactive disease. Close to 90% of patients would, in the study in 2015 that was done, showed that 90% when the anti-TNF agents were withdrawn, they flared within the year. So some kids who have had more aggressive disease will flare when they come off their medications. And then the point is that even though your child flared, they can still go into remission. It's just, it becomes harder, to put them back into remission, but that is, again, a possibility. We talked about polyarticular GIA. So the ones that have a harder time with going back into remission are those who have a rheumatoid factor that's positive. That's an antibody that is a pretty large antibody and can actually cause joint damage directly. And so those are harder to put into remission. And then the same study kind of looked at actually Wallace's study in 2005 looked at remission off medicines. They lasted for 2 years. So for, close to 30% of the patients actually were in remission for 2 years, and then they needed to be on medications again. So they're biomarkers. Some of them are actually not available commercially, like this S100 protein. We don't use that very often. We do use the C-reactive protein. The soluble IL-2 is a send-out lab, so it's not very practical because the result doesn't come back the same day, so you really can't help with prediction of flare, but sometimes we do that in the systemic onset GIA, especially if we're worried about macrophage activation syndrome. This really helps us identify those kids. And then MSK ultrasound. So MSK ultrasound is becoming a big thing, or MRI, which is a little bit harder to do because you have to go in. It's a 45-minute test. But a lot of pediatric rheumatologists are getting experience in MSK ultrasound, and it can tell you if there's joint swelling or not. So that technology is being more incorporated into looking for if there's inflammation or not. And there's been times when my patients have said, hey, I feel really good and I feel some fullness. I'm like, I don't know if, I don't think you're in quite remission, and we'll do an ultrasound or MRI, and there's actual tenosynovitis or synovitis. And so then we have a more objective reasoning, with the family, like, hey, I know your child feels great, but there is this swelling that's noted, and we shouldn't take them off medicine. We may even should increase the medicine a little bit to get them completely better, because as long as there's inflammation at the muscle, ligament, tendon, and bony level, there can be joint damage, right? And we don't want to lose integrity of those joints. We already talked about this. Okay, so these are the various medicines. I'm not going to go over all the medicines, but just to let you know that in 1950 we barely had anything, and in adult patients, gold shots really and steroids was really the way to go. And when I started my fellowship, there were a few patients who were in the practice who had received those gold shots. We weren't giving it, but I got to speak to some of those adult patients, and it was not a good experience. And then, in the 1990s is when the biologics started coming. Methotrexate came in the 1980s, and then we got more of the conventional DMARDs, and then the biologics have just taken off. And in 2024, we have just so many biologics, and they're more in the pipeline. I do adults clinical trials, so those, when they're approved, then the FDA requires it to be tested in adult population first, because kids don't get they're not old enough to kind of give an informed consent. And so if it gets approved in adults, that's when it can be tested in pediatrics. So there's a lot in the pipeline, so lots and lots of hope for our children, and so really your goal with your team, which is your child, yourself, your rheumatologist, your ophthalmologist, should be, hey, how can we put this child in remission, and how long will it take? What are the different options? And really work closely, make sure you're coming in when you're scheduled to come in. So if it's, 1 month, if it's 3 months, keep those appointments, keep the appointments with the ophthalmologist, and just, have this holistic approach. Make sure you're getting your kids the exercise they need, make sure that they're eating healthy, make sure they're sleeping and not on their electronics all the time. It's all going to help the immune system work better, so that they can stay on their medication if that's the plan that the rheumatologists and you guys have for them. I think this is my last slide. Yep. So we finished early. So if you guys have questions.
You had said that it's not normal for kids to have elevated liver enzymes on the methotrexate, but my daughter does. She's 5.5. What do you recommend?
Would I recommend next if she has liver enzyme elevation?
Should I? Yeah, I.
So it depends on the liver. So the studies show that if it's not 2 times above the upper limit of normal, so usually the upper limit of normal is 40, close to 40. If it's not 2 times, so that would be 80, you can continue methotrexate, okay? So it could be that the rheumatologist is like, hey, it's 50, it's 60, but let's just watch it, let's continue this. It could be that they switch from oral to injectable, but injectable can cause liver enzyme elevation too. Sometimes if if they have, is she taking more medications for other reasons, or does she only have juvenile arthritis and she's only on those medicines?
She's only on Humira and methotrexate. She
Yeah,
was
so-
taking Celebrex for a long time in
Yeah.
addition to those.
Yeah, so sometimes there are other choices. So there's sulfasalazine, there's luflunomide, there's hydroxychloroquine, which hydroxychloroquine I love, but again, it's not as strong as the other medicines. And so it could be you talk to the rheumatologist and say, hey, you know what, if this is really very high liver enzymes, can we try the other conventional medications like sulfasalazine or luflunomide? That would be a choice. And just because one made the liver enzyme go up doesn't mean the others will too.
Okay, thank you.
Hi, I've read a few articles recently about how something called inverse vaccines are being tested for autoimmune diseases, and specifically in the articles it mentioned something about being tested for rheumatoid arthritis in adults. And I'm just curious if that's something that's also going to be coming down the pipeline as a test for our kids that could potentially provide a cure in the future, and if not, why we're not testing it yet.
So so CAR T is so all these therapies that are looking for cures, they're being tested in adult population first to see if is the benefit outweighing the side effects of the medications, and is it going to cause new problems, new autoimmune disease, new issues, and that's when the FDA will give permission for pediatrics to be, the pediatric community to be tested. And so, so anything that's being tested on the adult side, if it becomes mainstream and it shows positive effect, then we can kind of mimic those studies in the pediatric population. A lot of the industries are trying to do 12 and above, but not for the infant vaccine, but for CAR T, we're going to be involved. There's some medication that they're looking at is 12 and above, and so at least we'll get the adolescent kids as part of the study, and then if that is a successful study, then we can do the younger kids 2 and above, because so many kids are 4 years old and they have a disease and they'll be exposed to the disease for years and years, right, decades. And so you're right, we will, but the FDA really wants to be careful about trying new things that have not become mainstream in kids who may not be able to give consent.
My daughter was taking Humira and it was working really well, and her rheumatologist wanted her to take it weekly instead of every other. The insurance denied it. Put her on Remicade infusions and she developed antibodies. So my question is it possible, because now she can't have any TNF inhibitors is my understanding, is it possible for those antibodies to resolve so that she could go back to trying Humira?
So the antibody she has is against the infliximab molecule itself. She could try other anti-TNF agent. We have done that especially, for instance, we have patients who have GI disease too, right? And so anti-TNFs are kind of the mainstream. I mean, they have other medications now, but the question is, are there other choices? And if there are other choices, like there's tofacitinib and there's tocilizumab, then trying something that's not anti-TNF may be in your child's favor. And I think that's why they may be offering you something different.
She's been on, I think, between 6 and 8 different medications and still not.
In remission, not remission. Yeah, so did they try Symphony Aria, which is golimumab, which is infliximab's cousin?
I don't think so, no.
So that is a humanized molecule. Symphony Aria is an infusion. It's not FDA approved for kids. I don't know how old your child is. So she's
just turned 18.
Just turned 18, so she's an adult. So she can actually, if they put down rheumatoid arthritis on her chart, we have to play insurance games here. So I usually do JIA/rheumatoid arthritis if this is an adult patient, and then some of the other medications then become available. So that could be considered.
Hi, I'm 20 years old, but they think I've had arthritis since I was a child. I was wondering why I would still have some swelling, pain, and stiffness 6 months after starting my biologic, but my MRI without contrast shows no active inflammation. Would moderate bone narrowing, bone spurs, or erosions be causing those symptoms?
Yeah, so I talked about, juvenile arthritis, but as you get older, you can have other forms of arthritis. For instance, I have a lot of patients who have hypermobility syndrome and juvenile arthritis, and the hypermobility is basically joints that are really loose, and so you can sprain without even knowing, strain without even knowing, and that can lead to swelling, stiffness, pain as well. And so sometimes those kids come in and they're like, hey, especially the ankle, because the ankle can roll, and if there's not good supportive shoes, that can really take a toll and a lot of stress on that joint. We'll get an MRI, and there's no synovitis or bone edema or erosion, then it's not the inflammatory component that's causing the joint issue. It's the mechanical component, and the mechanical component could be flat feet or like continuously dislocating or subluxating, meaning a little movement that's extra instability. And so that treatment would be more like the supportive shoes, physical therapy, taping, the braces, non-steroidal anti-inflammatory to get that under control.
Hi. So our son's 7 years old, and he has poly. So looking at the percentages that you had on your slides, which were kind of similar to what we saw last year, he's on methotrexate and Humira and doing well. My concern would be with his poly, seeing the percentages of being able to get into medicated remission or become off the meds, I guess I should say. And then the small percentage of that can make it to 2 years before having to go back on. And then I guess I'm concerned about the percentages that I see about how harder it is to get rid of when it does come back. My question would be, with your patients in that situation, do you ever recommend coming off the meds or staying on to ward off the possibility that it's harder to get rid of again?
Yeah. So as far as Humira, because the body can make antibodies to it, we try to keep another molecule there, some methotrexate or sulfasalazine to prevent that medicine from becoming ineffective, right? So that's why the combination. But I try to get some of those kids who are in remission on medicine, and let's say 2 years have gone by, they're in remission, they never have a flare. Whenever they come in for follow-up, they don't say, hey, I had a flare 3 months ago, I try to decrease the dose of methotrexate and try to get it down at least so that the potential for side effects is less. For the adult patients, sometimes this is off-label, but sometimes instead of every 2 weeks, they'll try to do it every 3 weeks, but this is all kind of off-label. There is no algorithm for this. But some kids will stop taking they go to college and they stop taking their shots, and they come back like, hey, doc, I'm going to just be honest, didn't remember to take it for 3 months, and I'm doing great. And so I say, okay, well, then this is our opportunity to watch you off of medicine, but you need to make sure you keep your appointment, and you need to make sure you know how to use, like if there's Epic, for us, we have Epic system, and like if you use the portal, you need to know how to use the portal so you can send me a message wherever you are, if you're in college, so that you can send me a picture of that joint if it swells up or, some other rash appears. So that way we can have this real-time conversation and not wait 3 months. It's kind of like the forest fire, right? If there's one tree on fire, we can get it under control. If there's like the whole forest on fire, it's so much harder, and then you're on boatloads of prednisone and whatnot to get under control. So I really want them to understand, hey, as soon as you start having that extra stiffness, you're limping or you're swollen, you see that, even though you can tolerate it, I need to hear about it so that I can do something and intervene quickly rather than wait for you to flare and come in your follow-up appointment.
So he pretty much asked most of my question, but I just want to follow up with one piece. So am I hearing you correctly that in cases of poly, given the likelihood of flaring after going off medication, that it's typically you wouldn't recommend coming off medication, or at least very quickly, and then if you did, that you would recommend very close follow-up to address flares if they begin?
Yeah, the CARA did a study called Stop GIA, to kind of answer this question, like, can we get patients off medication? And that's where some of the data is coming from, that they may stay in remission for a few years, but then they may flare. And so at this point, we don't know what the right time is, right? Like, do we give them drug holiday for 2 years and then get them back on all these medicines for another 2 years and then give them, so at this point in time, with the evidence we have, we try not to take them off medication. We try to lower the doses of medicine so that there's less exposure to the drug.
Thank you. Oh my. Great talk.
Thank you.
Quick question, because you're talking so much about kind of monitoring remission and looking at flares. I just kind of wanted to ask about your experience maybe with thermal imaging, with using that technology that is becoming a lot more affordable. You can do it with a smartphone now. There's several studies out there of doing it for diagnostic purposes. If you've seen any data about that related to flares, whenever you're in medicated remission, trying to monitor those.
Yeah, I'm not aware of any studies looking at remission with thermal energy at this point. The ACR is in November, so maybe I'll hear some more then. But at this point, no, it's not mainstream. We're not using it mainstream to even diagnose because we have the MSK ultrasound in the clinic, and then we have MRIs, so if we need to use imaging. So we're at this point not even doing that, to diagnose. I think it's still kind of more in the experimental, like, hey, could this become mainstream? Could this be a very practical technology to have in all our clinics? And then I think the next question would be, hey, could this help us with the remission? So I don't think we're there yet.
Okay.
You mentioned a couple times about correct shoes or
Yes.
supportive shoes. How do we pick them?
So there's a lot of shoe stores that actually have those technology where they make you walk, and it'll pick up where you're putting the pressure on the foot, and then they can suggest what shoe would work. But physical therapists also can assess. Especially if your child has flat feet, they can really assess and do some of the same. Like, they'll just watch their gait, they'll watch them walk, they'll see if they're doing kind of their hips dropping or not, and where's their foot landing, in toe, out toe. They can kind of watch that, and they can also recommend a shoe. But a lot of, for instance, if you're from St. Louis, there's the Big River Running Company. They have that technology. But Comfort Shoes, there's a lot of shoe stores that actually have that technology now, where they can have you just walk and then can tell you, hey, you're putting a lot of stress right here, and this is a really good shoe. Most kids need arch support, meaning heel support and a wide toe box and nice cushioning there, but shoes should not be heavy. They already have arthritis, should be really kind of light-based shoes. Again, they should be able to wiggle their toes in the toe box and then have really good cushioning at the heel.
Okay, thank you.
Welcome.
Hello.
Hey.
So my daughter was diagnosed almost 10 years ago. She's oligo, ANA positive, RF negative. Started with one joint and is now up to 7. So we're in that extended. But she has multiple fingers involved. So our doctor treats her as poly. Is there ever a time that we leave the oligo diagnosis behind?
So officially, she's considered oligo extended. But then when she comes to the adult world, she's going to be called rheumatoid arthritis, I'll tell you, because the adult rheumatologists don't understand our lingo. And so when they see her hands, they'll probably just start calling her rheumatoid arthritis. But really, that was to help figure out like how aggressive we need to be in the pediatric world. Now, because a lot of the medications are FDA approved for both adult rheumatoid arthritis and pediatric juvenile idiopathic arthritis, it actually, on the adult side, it opens up more doors because there's more medications. But yeah, no, she's always going to be oligo extended.
Okay.
Yeah.
Thank you.
You're welcome.
I'm just curious about, you've talked about liver numbers. I'm curious with the kidney numbers, because with the liver numbers, you said you can go up to double, but what about the kidney numbers? Yeah,
so the kidney numbers, kidneys are not as often affected with this medicines in the pediatric population, but every 0.1 increase makes a difference. So, and a kidney, the creatinine is based on the child's age and their weight, so it's kind of calculated based on that. So, an 8-year-old should be like 0.8 or less, and so if it's going to, 1.0, 1.1, we're paying attention to even that little increase. And usually it's a non-steroidal anti-inflammatory, and that's what needs to be stopped. It's not the methotrexate, it's not the Humira, it's not the biologic medications, it's the non-steroidal anti-inflammatory, so naproxen, meloxicam, diclofenac, those category of medicines need to be stopped. Hydration needs to be increased. Kids don't like water as much these days, and so we need to hydrate them a lot more and avoid kind of sodas that dehydrate, and hopefully those numbers will get better, unless there is some other insult. I don't know if they have diabetes or other kind of high blood pressure, because those two components will put a lot of strain on the kidney, high blood pressure and diabetes. So if that's there, then there's a different process going on that could stress the kidney out.
You mentioned the CARA study and related to poly kids and coming in off medicine into remission. Were there any other data points that could directionally provide guidance on when to kind of give it a try, like their current age, not being in puberty, being past it, maybe how long it took them to go into medical remission, their gender, other data points that could help parents kind of think when to potentially push it when their kid's not showing symptoms?
Yeah, I don't think those studies, even though they did correct for ethnicity and age, I don't think they reported on the age group, like, hey, this age group will do better. And puberty, interesting that you say that. May or may not, so the jury's out, like, hey, what, do we really, like some rheumatology disorders like scleroderma and such, we really pay attention because we feel like puberty is going to be the time when they're, lupus is going to flare during puberty. GIA, not so much, even though it happens more in girls, estrogen levels are not high. Girls are 2 years old, and so estrogen, the driving force for some of the other diseases, is not as much for this. So the puberty part is, so we don't necessarily say, hey, if she gets over this hump or he gets over this hump, then they're in the clear. That it's really the number of joints, the antibodies that they have. How soon did they go into remission? Those kind of components have in multiple studies kind of been kind of the leading force to guide us. So a positive rheumatoid factor in CCP child will have more difficulty, staying in remission off medication. And an ANA for the uveitis, that is going to be driving a lot of kind of uveitis data. And then, a younger child with poly, is going to have a harder time going into remission or staying in remission if they come off medicine. So, but we don't have like ethnicity data or puberty data to guide based on that.
Our daughter had remission a few years back, ended up having a flare-up and developed antibodies. So we switched her to Humira, which has worked great for the past 5 some odd years. Unfortunately, our insurance forced us off of Humira to biosimilar, the adalimumab.
Yeah.
And she's been on it for about a month and has been observing more pain over the course of that month, so not as effective. So curious on, after we go the 3 months, to see if it is as good or we need to switch back. How effective are these biosimilars to Humira itself? If we tried to switch back, would she have antibodies on Humira now to make that not work? Or what would be the next recommended medication for her?
Yeah, we are dealing with that too. So we have kids who have been, their insurance has forced them to switch to biosimilar, and no letter of like medical necessity has made the insurance waiver their decision. So we do have some kids. Some of them are doing fine, and like you just mentioned, the other kids are saying they have more stiffness or pain, and so we are trying to switch them back to Humira. As far as will they have, so number one, biosimilars. The way biosimilars came on the market, they had to check their pharmacokinetics, meaning how does the medicine absorb, work, and then the pharmacodynamics, how does it work in us. They had to be very, very similar to the original product, and so, but there are a couple of head-to-head trials with, and all biosimilars are not equal. There are a few of them there, and some companies did the head-to-head trial with the original molecule, and they were as good as biosimilars. And so that's number one. But I am seeing kids get more pain when they were in remission on the original medication, and I plan to switch them back, at least if the insurance allows. If the insurance doesn't allow, then I'm going to switch the biosimilar to a different biosimilar. And if that still doesn't work, then I'm just going to get off the anti-TNF, like the adalimumab molecule itself, and move on to something else, because I don't want to wait too long, and then they're really in a bad flare. So that's the kind of the plan that we are at Children's Hospital are kind of following.
So I was wondering about potential long-term effects of being on like the methotrexate and the biologics for such a long period of time. Can you talk about that at all?
Yeah, so I will talk from the adult perspective, so I've had some pediatric patients who were part of the original etanercept study in 1998, who continued on with that medication, got married, and still were on it because if they had polyarticular GIA, so they were methotrexate, and did well. And we had data for when to start the medicine. We didn't have data when to stop the medicine, right? And so. So these patients, when I inherited them, they had been on it, and I was not in the original study. In that 1998, I was not a rheumatologist, so I was not part of the original study. These are just kids that I inherited in my clinic, and so they were doing well, like their liver enzyme, from the cancer perspective, from just general quality of life, heart, lung, everything. They were doing well in their 20s and such. From the adult data, we have some patients on biologic now for 20 years, and RA patients are more prone to cancer, and so we're really looking for like breast cancer and lymphomas, and we're really scanning. So I've had patients get the cancer, and we've had to take them off, and we've worked with their oncologists, and their oncologists are saying, hey, you can get them back, and they finished their chemo, you can get them back on methotrexate now. So before, when I was a fellow in 2004, they'd be like, okay, they're off. The oncologist would say they're off and don't get them back on, and now in 2024, they're the ones saying, hey, I'm good with it. I'll watch their cancer, and they're in remission, and their arthritis is the big issue, so get them back on the disease-modifying agent. So as far as if cancer were to happen in the adult population, we'd stop all biologics for 5 years for solid tumors, but there is rituximab that is FDA approved for rheumatoid arthritis. Some kids may have gotten it here in the room, I don't know, but it's not FDA approved for juvenile idiopathic arthritis. It's FDA approved for rheumatoid arthritis, and that is a biologic that does not cause cancer. It's actually used for non-Hodgkin's lymphoma, and that's where we got the data from and did the trials for it. And so we have that in our adult population. So in our pediatric population, if the child is 17, 18, and something happens where they can't use the other biologics, then we have this biologic to help treat their arthritis. So we are still using biologic. It's just a different biologic. But as far as long-term data, yes. On the adult side, we've seen some cancer, but I think the disease is different. This is RA, not GIA. I have not had a GIA patient on the adult side, be referred to oncology for cancer, and we're watching very closely. The liver enzymes, really, it's the call, you go to college, you start doing the partying, and that's when we're seeing liver enzyme elevations. We have good enough relationships. Well, we'll get the lab and I'll send a message, on Monday, like, hey, was the weekend really exciting? Your liver enzyme's slightly elevated. And they'd be like, yeah. We had a little bit of fun. Okay, let's repeat the liver enzymes in 2 weeks. Please don't drink alcohol. And that way I know if it was the alcohol or the drug, and then it comes back down. So it's nice to treat those young adults as adults, because I don't want them not to have fun, but I want them to become responsible, and I think this is a nice way, because you're being non-judgmental and you're saying, hey, this is what we see, and they can see it, and then, and then they can see the difference. Hey, alcohol does make my liver enzyme go up, and so I think that's there. Multiple comorbid illnesses can make the liver enzymes go up. So from not the pediatric data again, but psoriatic arthritis data, a lot of, so we've seen psoriatic arthritis patients, a lot of them are overweight, and that can cause something called non-alcoholic steatohepatitis, which means the liver enzyme can be up because of the liver having to filter the fat tissue out. And so the new terminology is NAFLD, NAFLD, which is the fatty liver disease. And so they, so psoriatic arthritis patients are more prone to that. So we definitely talk to them about it, like, hey, I am starting you on methotrexate, but you could potentially have that underlying disease. And it's not an algorithm to check for that. We check their baseline liver enzymes, but we say, hey, you're more prone for the liver enzyme to go up when I start this medicine. So be careful. Don't drink alcohol. If you're starting a new medicine, I want to know about it, and we're going to check the labs pretty quickly. In the psoriatic arthritis data, because there is that overweight, so a lot of companies are now trying to look into these new molecules, Ozempic and whatnot, and seeing if a combination of Ozempic and a biologic for the arthritis will be a better way to do it. So I was talking to one of the companies, and they're like, how interested would you be in that? I'm like, very interested, because, these patients are more prone to, getting the problem. So definitely. So they're looking into that, but so it depends on which part of the disease you have, what other illnesses you have, that has an impact on the side effects too.
How about like reproductive issues in particular?
So methotrexate is a class X. You cannot get pregnant on methotrexate because it has teratogenic effects on the baby. So for 4 months, you need to be off of it, boys and girls, and then plan pregnancy, right? So we definitely don't want that. Now, do I have young adults who got pregnant on methotrexate? Yes, I do. And did the mom and the baby do okay? Yes, they did. But the data is that there can be a lot of problems with the baby, and so we really don't want that. We really want planned pregnancy. Arthritis tends to get better during pregnancy. It tends to go into remission and then flares postpartum period. And so a lot of patients were like, oh my gosh, I feel just amazing, And so as far as the biologics, actually, what etanercept specifically, we had adult RA patients who were having a hard time conceiving, but then etanercept came on the market for their RA. They started that, and they were able to conceive. So inflammation itself actually hinders conception too, and these biologics are class B. So B is a pretty safe drug, so it's not zero, and there's many registries. One of them is the OTIS registry, OTIS, and you can actually go on their website and go drug by drug and kind of look at it. But the biologic medications are doing really well. We have really good data that people can get pregnant, it's not holding people back, and it's not affecting the pregnancy outcome, the fetal outcome or the mother's outcome.
Okay, thank you.